Thursday,
Okay.
Friday, Saturday, Sunday, 9 to 6.
Yeah.
Saturday, 9 to 3 and Sunday.
Hi. If I've never talked to you before, I'm Jada. I'm one of the I'm the new officer. I'm going to be covering dysautonomias today, specifically POTS and orthostatic hypotension. So autonomic nervous system, it regulates involuntary automatic functions of the body. Dysautonomia is pretty much just when something in there malfunctions and it's just not really working right, it's not as coordinated as it should be. Since it has so many different things, dysautonomia patients can present with a ton of different symptoms that might not seem like very related. Like someone comes in with like dry eyes and headaches and heat intolerance, and they're like, I'm dizzy when I stand up and I'm constipated. Like, and someone would be like, okay, get some eye drops then, like, but it could all just be something with the autonomic nervous system. So there's around 15 forms of dysautonomia, and they can range, or patients can range from having mild symptoms, they can go about their day just as normal, or some people are like in wheelchairs, bedbound. It's really just depends on the case. In some cases, dysautonomia is a primary condition, but oftentimes it is secondary to another condition, such as celiac disease, Chiari malformation, Crohn's, Ehlers-Danlos. I'm not French. Is that Guillain-Barré?
Yeah.
Okay. Lupus, Lyme disease, MS, diabetes. The most common is the vasovagal syncope or neurocardiogenic syncope. Like Elisa said before, it's just like you fainted. Yeah, like congratulations. There was some sort of stimulus, like standing or seeing something that just sets it off for you. Like I feel like blood is one that's like they say is something for people, and you just and in that one, typically your heart rate and your blood pressure will both drop when you also drop. But we're gonna go deeper into the other two. But some of the common symptoms, not all of them, tachycardia, high heart rate, like over 100 typically. I didn't put it on there, but you can also have a low heart rate. Syncope, what most people might think about when you think about dysautonomia, but with most of the conditions, it's only like about 30% of people will actually ever pass out. Dizziness, lightheadedness, weakness. Like I have some form of dysautonomia, and when my symptoms started to appear, it was really weird because like I lived on the second floor of my apartment unit, and like one day I just suddenly like I couldn't walk up the stairs. That was like I felt like it was really rough, like walking up the stairs, and like we had to take the trash to the compactor, and like I could barely like take the trash, and it was just really weird because it wasn't like that before. Shortness of breath, like you can't get enough air in. Maybe you feel like you have to focus more on breathing, and like I know I'm getting oxygen in, but like it just feels like it's not really, but I know I'm not gonna die, so it's fine, I guess. Chest pain and tightness. For some people it feels like pressure, tightness, squeezing, or like stabbing, which is really nice. Heart palpitations. I've heard it most described as like your heart skipping a beat, but I really didn't even know until preparing for this presentation that it can also be like your heart is pounding more than usual. It feels, you're just more aware of it, or it feels like it's going faster, but you like feel it. I didn't know that. Tremors, fatigue, blood pooling, your legs might feel really heavy and you might have swelling, and it gets like real blotchy, red, purple, all on your hands and feet, sometimes up the legs. Increased or decreased sweating, headaches, migraines, brain fog, heat or cold intolerance. I know with POTS, it's super common to have heat intolerance, and people are like, I cannot stand being in anything under 60 degrees. I like have a fan on me all the time, have to be in the AC, carrying ice packs with me to like cool myself down. But I'm always freezing. I don't know. I've literally never worn a t-shirt in the buildings here because like I'll have to leave. Yeah, shivering. Neck and shoulder pain. It's sometimes called coat hanger pain. It's often worse when you're standing and it gets better when you're laying down. I saw a theory that it's because your neck muscles are like anti-gravity muscles, and so they're continually using oxygen from the blood when you're upright and your head's not just like supported by something. And if your blood flow isn't sufficient, then like waste products can build up in there and just cause it to like really hurt. Nausea, vomiting, diarrhea, constipation. Also, you can have difficulty with urination, having a sudden urge to go to the bathroom, leakage, difficulty of peeing, waking up in the nighttime, vision changes like light sensitivity, blurry vision, visual snow, changes in color saturation, and dizziness with certain eye movements, dry watery eyes, sound, light sensitivity, anxiety. So with POTS, it's postural related to position, orthostatic related to standing upright, tachycardia, heart rate over 100 beats per minute syndrome. More than 75% of patients are female, and it starts on average when you are 15 to 25 years old. The diagnostic criteria is just that you stand up, and within 10 minutes of standing, your heart rate increases. For adults, at least 30 beats per minute, and it stays that way. For children, it has to be at least 40. And you can't have orthostatic hypotension. So you can't have like a severe blood pressure drop during that time. Symptoms for at least 3 months, and no other conditions that would increase your heart rate. And then, like the most common symptoms, dizziness, lightheadedness when you're standing or walking, syncope, pre-syncope, brain fog, those heart palpitations, race of heart, fatigue, nervousness, anxiety, all of these things. And what's going on is that the autonomic nervous system like coordinates the blood vessel constriction and the heart rate. And in POTS, it just kind of can't keep up with what's going on. So when you stand up, your blood vessels aren't like constrict, or they're not getting enough blood back up to the heart. So the heart kind of is like, and it triggers the release of epinephrine and norepinephrine and causes your heart rate to go up, and sometimes like the other symptoms. And so it's considered like a compensated neurocardiovascular dysfunction. Orthostatic hypotension, just when your blood pressure drops a sufficient amount when you stand. It's roughly 6% of the general population, and a lot more common in older people and people with like those various comorbid conditions. And it's a lot more common, I already said, in older people. If you're over 65, it's about 20% of the population, and apparently it's also common in teenagers who are kind of like in the middle of a growth spurt. The diagnostic criteria is just within 3 minutes of standing up, your systolic blood pressure drops at least 20 millimeters of mercury. I cannot talk. And or the diastolic drops 10. And it can be within 15 seconds, between 30 and 3 minutes, or delayed. And I guess it's just different, but the treatment is generally the same. And the symptoms are pretty much the same as POTS. It's just different that it's not really compensating and typically making the heart rate increase so much, so fast. Some people with it, the heart rate will spike, but it's typically not so severe. So the like gold standard for the diagnosis of these dysautonomias is the tilt table test. I hope it's not too loud.
Falling over if they faint during the test. The patient will be hooked up to cardiac and blood pressure monitors. There may also be a pulse oximeter to measure oxygen levels, though oxygenation is not impacted by POTS. The patient is left fully supine for 10 minutes to establish a baseline heart rate and blood pressure, at which point the table is tilted upwards, most commonly to an angle of 70 degrees, at which point they are observed for changes in heart rate and blood pressure. By definition, a patient with POTS will experience a significant heart rate increase, while the blood pressure is usually minimally affected. These changes reverse when the bed is tilted back down. In contrast, for patients with orthostatic hypotension, there is also an increase in heart rate, though not usually as pronounced or rapid an increase. But more importantly, from a diagnostic perspective, patients with orthostatic hypotension have a prominent decrease in both systolic and diastolic blood pressure.
So I would assume that most chiropractors are not going to have a tilt table like in office. They do have like a poor man's tilt table test that you can do. You can have the patient lie on their back, legs uncrossed for like 5 to 10 minutes and take their heart rate and blood pressure. And have them stand up, make sure they're as still as possible, not crossing their legs, and then take their heart rate and blood pressure measurements at different increment. Like they say, if you want to be checking for both POTS and orthostatic hypotension, check it at 1 minute, 2 minutes, 3 minutes, 5 minutes, and 10 minutes. But if they feel like they're going to pass out, make them sit down or lay down, because that would not be good. I've also seen that you can use a high-low table, but like the strap, so that the person doesn't pass out, I feel is kind of important. So I just got that from Google AI, so I don't really know that I trust that, but.
The table itself is a bed.
And then there's some other tests that they might sometimes do, like a Holter monitor that you'll just have on you for like 7, 14, 30 days, like a tiny little EKG to see what your heart's doing the whole time that you have it on. It looks tiny in that picture, but it's not tiny. I'm convinced that they like try to find the person with the largest possible hand to make it look tiny. It is not.
It's for sure bigger than that.
Yeah.
I'm for sure bigger than that.
Mm-hmm. Like that was the one that I had. No. They will do sometimes an echocardiogram, ultrasound it, just to make sure that there's nothing like structural in your heart that's the underlying issue. Acute sort or sweat test sometimes, where they put electrical stimulation on your skin and just measure how much you sweat, how long it takes you to sweat, when you sweat the most, and what's your total volume of sweat. And then sometimes various blood tests just to rule out other issues like vitamin deficiencies. Some common triggers are dehydration, hot environments. I think that's interesting because like a lot of the people, like I said, will have heat intolerance, but it's like not just those people that it gets exacerbated. When you're in a hot environment, like I love hot environments because I'm always freezing, but they still make my symptoms worse. So exercise, if you like overdo it, especially alcohol, caffeine, so bad. Carbohydrates, illness, infection, stress, pain, high altitude. I guess we don't have to deal with that here really, but long periods of rest, like bed rest, especially surgery, allergic reactions, and certain medications like stimulants, diuretics, and SNRIs. Some lifestyle modifications that they will typically have you do for this are increase fluid and electrolyte intake to like 2 to 3 liters of water per day and 3 to 10 grams of salt per day. Compression garments. I read a study on Wednesday that was comparing different like kinds of compression garments, and they said that like in order of effectiveness, it's like full compression, feet to xiphoid process is the best, and then abdominal compression or compression socks like up to your thighs are like second best, and then if you have like to your knee, that's better than nothing, but it's not the best. Small frequent meals as opposed to larger meals. Elevating the head of the bed like 6 inches or so. Exercising, which is kind of funny because it's like it can mess with you but also help. But they particularly recommend cycling and swimming. Swimming can be good for like the compression on your body. Focusing on the lower body may be helpful, and there's a like exercise protocol that I found called the CHOP protocol. It's a specific exercise regimen that like starts really slow. You're just kind of sitting there, and then it just like ramps up. Moving more slowly when you're changing your body's position, especially to standing. Counter maneuvers. Like these one, I did not know what they meant. Okay. So just like stuff like that. When you start to feel dizzy or whatever you're standing. Okay. And it's not really obviously our scope, but various medications sometimes to increase fluid volume, increase blood pressure, decrease heart rate, depending on the case. And as chiropractors, you can do eye movement therapy, like we've been talking about with a lot of other things. We're training your brain in whatever way that the individual brain might need training. Vagus nerve stimulation has been found to be effective. There's like little devices that you can use. Also like gargling, singing different notes, kind of like having them close their eyes and apply like a really gentle pressure on the eyeball. On the eyelid. With chiropractic adjustments, they've found that cervical adjustments are sometimes helpful. Anterior thoracic adjustments will help regulate the sympathetic nervous system, and like craniosacral techniques will sometimes be effective. Vestibular rehabilitation is another thing. I was looking at like different ways of doing that last night, and they have this gyro stem, and it looks like kind of like the little astronaut training thing where they have them like flying around, but they start the patients like kind of gently, like not flying, just kind of moving a little bit, and then it like ramps up. But there's that. Red light therapy. They say it helps the circulation, specifically in the legs with like the blood pooling. I don't know if that's Beamer. It's like electromagnetic pulses that also increase circulation, and you can recommend different dietary supplements. Like a lot of patients will be low in vitamin D, B12, and B1, and getting those levels back on track will help some patients with their symptoms. Other ones that I've seen that are good are B9, iron, magnesium, choline, but maybe not for everyone, and other supplements might be helpful for other symptoms as well on a case-by-case basis, since the treatment's not going to be the same for every person because it shows up so differently sometimes. I just wanted to say, like, if somebody comes in with these symptoms, like, please listen to them, because a lot of doctors know nothing about this stuff, and like I know that not a whole lot of research has been done on it, and a lot of doctors will just like write patients off and be like, it's all in your head, you got anxiety, and like the average time to get diagnosed is 4 years, and those people usually would have seen like on average 7 doctors prior to getting diagnosed, and probably not gonna like cure the whole thing, but you can help your symptoms improve and give them better quality of life. And for a lot of people, that is